I just want to begin by acknowledging the contribution of the participants in the study, all of whom are people living with HIV and who use drugs, and all of whom are impacted by intersecting and overlapping socio-structural inequities. So North America is currently experiencing a syndemic of HIV and overdose, which is disproportionately impacting people living with HIV who use drugs. And so we undertook this study to understand the impact of receiving safer supply-oriented interventions among people living with HIV who use drugs. We wanted to look at how engagement with safer supply-oriented interventions shape the drug use patterns, the drug use practices, and the overdose risk of people living with HIV. And we also wanted to explore how the engagement with safer supply-oriented interventions influences the management of HIV and other comorbid conditions. I'm not going to go into a lot of detail here again. Dr. Kerr gave a wonderful talk yesterday about this, and Lucas talked about a bunch of stuff here as well. There's a panel again tomorrow about safer supply, but essentially the concept of safer supply refers to providing people with alternatives to the toxic and unpredictable, unregulated drug supply. And these are being alternatives of known quality, of known potency, of known content. In Canada, this primarily means prescribed alternatives. Most people in Canada getting safer supply are getting tablet hydromorphone, which goes by the brand name Dilaudid. A typical prescription in British Columbia is about 10 to 14 8-milligram tablets a day. But there's other programs providing different medications. Lucas mentioned some. But we also have programs that provide diacetylmorphine, different forms of fentanyl, so fentanyl patches, sublingual fentanyl, injectable fentanyl, and there's also a program in Vancouver that we've been evaluating that provides fentanyl powder. I won't be talking about that program today, but that's another program that we've been evaluating. So this is a qualitative study made up of two parts, in-depth interviews and an ethnographic component. So we conducted 53 in-depth, semi-structured interviews with baseline interviews between May and November last year. We then did mid-study check-ins, so these were done about 6 to 8 months after people had done their baseline interviews, just to really keep in touch with participants. It involved a very short 5-minute questionnaire to capture changes that people might have experienced since their baseline interview, so things like changes to their healthcare, HIV, safer supply, drug treatment, and we only managed to reach 30 participants for this part. We're currently in the middle of our 1-year follow-up interviews. So these are in-depth interviews with participants 12 months after their baseline interview. Obviously, these are intended to capture and explore changes over time, but we're also using these to include topics that came up from our baseline data analysis that we feel the need to dig a bit more into, including some of the stuff I'm going to be talking about today. We also have an ethnographic arm of the study, which involves informally spending time with study participants every 3 to 4 months, and this is taking place over the course of 1.5 to 2 years. And we have 10 people enrolled in the ethnographic part. It's pretty time consuming. It involves very casual hangout sessions. So this might include going for walks around the neighborhood, getting a coffee, sitting in the park. Sometimes they invite us to go with them to medical appointments. There's one participant that he just wants me to take him for breakfast every time we meet. But these are really allowing us to get a richer and deeper sense of the participants' lives. So today I'm presenting data on from our baseline interviews, which is focused on the experiences of receiving safer supply. And we carried out this analysis in 3 stages. So first, we really wanted to get a sense very broadly of the impacts of receiving safer supply. We found some really interesting stuff happening in there. So we decided to compare the experiences of participants based on the medications they were receiving. So we divided the sample into two groups. Those receiving hydromorphone as their primary safer supply medication, and those receiving other non-hydromorphone safer supply medications. So in our study, that's people primarily getting diacetylmorphine or some form of fentanyl. We then also decided to map people's experiences across on how they were accessing their medications. So 24 participants were receiving tablet hydromorphone as their primary prescribed safer supply medication. Often these participants were also co-prescribed OAT or methadone typically. 20 participants were receiving other safer supply opioid medications as their primary medication, so 11 were getting fentanyl patches, 7 receiving diacetylmorphine, and 2 were receiving fentanyl powder. 7 participants were also receiving stimulant safer supply, some of these in conjunction with an opioid medication as well. And 2 participants at the time of the interview were only receiving methadone. So really, in general, our findings mirror other studies on safer supply. So participants talked about using less street-purchased fentanyl, which thereby reduced their overdose risk. Participants also talked about how their safer supply medication was effective for managing withdrawal and reducing cravings. Some participants described positive economic impacts, such as having more money to spend on things like food, clothes. They talked about buying books. Others talked about not having to engage in criminalized or stigmatized forms of income generation as much, so things like theft or panhandling or sex work. And finally, participants talked about impacts to their health and well-being. So this included a wide range of things like sleeping better, having less anxiety, eating better, taking care of dental issues, attending medical appointments more often. However, when we compared the two groups, so those receiving hydromorphone with those receiving other opioid medications, we found that study participants receiving non-hydromorphone, so those getting diacetylmorphine or some form of fentanyl, were more likely than participants receiving hydromorphone to report positive impacts across all the outcomes. So if you've been following the research on safer supply in Canada, this may not be all that surprising given what we know about hydromorphone. It shows that it's simply not strong enough to match the potency of the unregulated fentanyl that people are using and buying on the street, and especially among people who've developed high opioid tolerances from using this highly potent and unpredictable fentanyl. So what's unique here is prior to this, most of the research on safer supply is focused on particular medications, primarily hydromorphone, and also specific programs. But here we've been able to directly compare these two groups and see side by side the different experiences people are having. So you can see here, for example, that 85% of those receiving diacetylmorphine or fentanyl reported using less unregulated drugs, whereas 45% of those getting hydromorphone reported doing so. The same is seen with economic impacts and withdrawal management. 90% of those getting non-hydromorphone, so those getting diacetylmorphine or fentanyl, reported positive impacts to their health and well-being, while only 33 of those getting hydromorphone reported positive impacts to their health and well-being. When we took a look at how participants were accessing their safer supply medications, we found that 39 participants accessed their safer supply as part of a system of coordinated dispensation along with their antiretrovirals. So they were getting their ARVs and their safer supply medications at the same time. Among those, 15 participants received program-based on-site coordinated dispensation, and these were mostly those getting diacetylmorphine or fentanyl. So this meant they were going to a clinic or a program every day that dispensed their safer supply and would be given their ARVs at the same time, both of which were often witnessed ingestion. There were 24 participants that had their medications delivered every day. So these were mostly those getting hydromorphone, and again, many in combination with methadone. And their ARVs and the methadone would be witnessed ingestion, and they would be given their daily prescription of hydromorphone. Some participants who were receiving the fentanyl patch were also having their patches changed by the delivery person or the pharmacist every few days. 4 participants were picking up their medications at a pharmacy, and there were 10 participants for whom we don't know how they access their medications. So what we found was that coordinated dispensing of ARVs and safer supply facilitated HIV treatment adherence. So participants said things like, it's a lot easier now, I don't forget to take my ARVs anymore, or it keeps me stable, making sure that I take my ARVs. The top quote here is from a participant who gets their diacetylmorphine from the Dr. Peter Center. And they said, I show up here every day to get my dose of diacetylmorphine, and that's where I get my ARVs at the same time. I used to go to Shoppers, which is a pharmacy chain in Canada, to get my ARVs, and I constantly missed them. And then below, a participant describes how having their ARVs and methadone delivered every day, along with their hydromorphone, supports their treatment adherence. And in this case, the methadone and the ARVs are witness congestion. And they say it goes hand in hand, and every morning when the pharmacist comes and delivers their medication, they take both. However, what we found was that those getting on-site, program-based, coordinated dispensation of safer supply and ARVs were more likely to report positive impacts related to their HIV care than were those getting pharmacy delivery. On the flip side, some participants described how daily dispensing of their medications was onerous and stigmatizing. So some explained that having to ingest their medications in front of a delivery person was especially stigmatizing for them. Other participants referred to temporal issues. So here, one participant who has to go to clinic every day said, my only reservation was that I felt like it was going to take away a lot of my personal freedom, having to come here every day, twice a day. Another participant who had their medications delivered every day described a common issue among people getting pharmacy delivery. So they said, my pharmacist comes daily at 6 in the morning, but sometimes I'm not awake or I'm not there and I'm just down the hall or something. I forget to put a note up and didn't realize the time, and all of a sudden they're gone. And then I'm just like chasing him because he can't leave my meds, right? He can't leave drugs. So in this case, the participant might have to go without their medications, their ARVs, and their safer supply that day. So I think our findings show that safer supply programs have the potential to play an important role in the ongoing drug poisoning crisis for people living with HIV who use drugs. But clearly, interventions need to be tailored to meet the needs and the desires of the people who are accessing them. So this means providing safer alternatives that people will use that give them the desired experiences that they're seeking from the unregulated drug market. So if people are using highly potent, unregulated fentanyl, it makes most sense to offer them something that can match the strength of that unregulated drug. This also means that a variety of program models should be considered. So some people liked going to a clinic or a program every day. Some don't. For some participants, it provides social connection, sometimes access to medical care or food alongside their daily drug use and medication needs. For other people, it's just a burden, which may act as a barrier to safer supply access. And our findings show that coordinated dispensing of drug treatment or safer supply interventions along with ARVs can facilitate treatment adherence. And I think this demonstrates the potential of integrating safer supply and HIV care on treatment engagement, including improved treatment outcomes, and also the management of other health concerns, including overdose risk. And finally, I think our findings show that innovations in harm reduction and drug treatment programs that really have been made necessary by the overdose crisis also have the potential to enhance HIV treatment and improve the lives of people living with HIV who use drugs. Thank you.
Thank you for the presentation. I think we have time for one quick question so that we can remain on time. Yes, in the back.
Thank you for your presentation. I wanted to ask, it seems like a lot of the safer supply is single substance. And so what kind of, we know that a lot of our supply, at least I'm in Kentucky in the United States. And so, for example, our meth has fentanyl in it, or our fentanyl has xylazine in it. And that also shapes consumer preference and choice. And so I just was wondering how that preference and choice in polysubstance use is kind of integrated into safer supply programs.
Yeah, I think that's the biggest challenge right now we're having in British Columbia and elsewhere across Canada, where benzodiazepines and xylazine are showing up in the drug supply, and folks who are receiving an opioid medication still need to purchase drugs from the street because they need those benzos or they need that xylazine. So I think it's certainly like a big challenge for these programs, and I don't know the solution. Yeah.
Thank you.
Thank you.